Dear college, our lecture devoted on hereditary skin disease, part 1, ichthyosis and ichthyosiform dermatoses. Ichthyosis vulgaris. Ichthyosis vulgaris is a hereditary skin disorder characterized by hyperkeratosis of epidermis. Ichthyosis vulgaris is a result of mutation with loss of function in the gene filaggrin and is clinically characterized by xerosis, scaling, keratosis pilaris, palmar and plantar hyperlinearity, and a close association with atopic disorders. Filaggrin mutation occur in about 7% of Europeans and from 0 to 3% of Asian population, but are very rare in African Americans. The following form of Ichthyosis vulgaris are distinguished: usual form, X-linked recessive and X-linked dominant form of disease. Ichthyosis vulgaris is inherited autosomal dominantly with a frequency of 1 to 3000. X-linked ichthyosis is a recessively inherited dermatoses with an incidence of 1 to 6000 in males. Ichthyosis vulgaris as a result of mutation with a loss of function in the gene encoding the filaggrin protein, with a chromosome 1q21 to 22 in the epidermal differentiation complex located. Mutation lead to the defective production of filaggrin. Filaggrin is an epidermal protein necessary for binding keratin fibers in epidermal cell to form an effective skin barrier. It helps maintain skin pH, retain moisture in the stratum corneum, and reduce transepidermal water loss. Xerosis or dryness as a result from reduced skin hydration, associated with a defect in filaggrin. Excessive flaking occurs due to the inability of skin cells to remain hydrated as they move up the stratum corneum. Hyperkeratosis as a result from compensatory repair mechanism that increase cell proliferation. Pathogenesis: filaggrin protein-like its precursor, profilaggrin, accumulate in keratogealin granules in the granular layer of epidermis, was synthesized. Defect in the synthesis of both proteins by thinning of the granular layer of the epidermis are characterized. Ichthyosis vulgaris patient dysaminoacidemia in peripheral blood by accumulation of some amino acid tyrosine, phenylalanine, tryptophan, threonine, as well as cysteine and lysine were detected. Ichthyosis vulgaris patient also dysimmunoglobulinemia with decreased level of A immunoglobulin, M immunoglobulin, and G immunoglobulin accompanied by increased susceptibility of pyococcal and viral infection were observed. Clinic: Ichthyosis vulgaris in the first month of life of newborns was appear. The skin becomes dry, rough, dirty gray with lot of scale, especially on the torso. Limbs except fold, palm, soles were revealed. Depending on the color of the scales, the nature of their attachment to the underlying skin, and their severity, xeroderma, simple, white, shiny, and follicular ichthyosis are distinguished. The skin of the face in adults is affected. On the skin of the palm, a clear pattern of skin lines in the form of fine folds were found. The nails are brittle, dry, and may be deformed. Skin grease separation and perspiration are reduced. The disease is lifelong. Clinical signs subside during puberty and in adulthood. Ichthyosis vulgaris with neurodermatitis, seborrheic eczema, cryptorchidism, and is complicated to pyoderma were often combined. On this slide, you could see the typical clinical form of Ichthyosis vulgaris, especially the localization of multiple dirty gray scales on the torso and on the extremities. On the slide, you could see the histopathology of the Ichthyosis vulgaris, especially the presence of retentive hyperkeratosis, medium hyperkeratosis, with thinning or absence of granular layer of the epidermis as observed. The papillary layer of the dermis as normal, hair follicles and sebaceous glands are somewhat reduced. X-linked ichthyosis. This form of ichthyosis was first described by Cochrane in 1933. Only males are affected. The disease is inherited recessively, linked to the X chromosome. Clinical signs develop soon after birth. The entire scan, including the folds, is affected. In children, the scalp, face, and neck are involved. Palms and soles are not affected. In contrast to Ichthyosis vulgaris, the scales are large, dark, and often shield, and massive lizard-type horny patches are formed. Eye damage in the form of cataract as characteristic of this dermatoses. In some cases, there is a mental retardation, epilepsy, and hypogonadism. The genetic defect by asteroid sulfatase function was expressed. Skin condition doesn't improve with age. There is a symptom of dirty neck scan. On this slide, you could see the typical clinical feature of X-linked ichthyosis. Especially, you could see the involvement of the fold in the pathological process, with dark-colored scales resembling shields, symptom of dirty neck skin. On the slide, you could see the histopathology of X-linked ichthyosis, especially on the first slide, you could see the mild hyperkeratosis and hypergranulosis with small dermal perivascular infiltrate. On the two slide, you could see the phenomena of hyperkeratosis, granular layer, normal or slightly thickened. Ichthyosis fetalis. Ichthyosis fetalis, harlequin-type ichthyosis, developed during the embryonic period, fourth and fifth month of pregnancy. The disease is autosomal recessive and is caused by a mutation in the ABCA2 gene. This gene encodes a protein required for lipid transport from cells in the outer layer of the skin. The ABCA2 gene contains information for protein synthesis that is required for normal skin cell development. By the time of birth, a complete clinical picture of the disease is formed. The skin of the newborn is covered by a horny carapace consisting of horny shields up to 1 centimeter thick. The mouth opening is distended or sharply narrowed. The eyelids are everted. The nose and auricles are deformed. The skin is covered with deep fissuras. Limbs are deformed. Club hands, contractors, aingum, hair and nails are absent or dystrophically altered. Most babies are stillborn or die shortly after birth from exhaustion and sepsis. ichthyosiform congenital erythroderma with bullous and non-bullous variants, as congenital ichthyosis was also classified. On this slide, you could see the newborn that suffered from ichthyosis fetalis. The skin of newborn is covered by horny carapace as consisting of horny shields up to 1 centimeter thick. The mouth of newborns is distended or sharply narrowed. On the slide you could see the typical histopathology of the ichthyosis fetalis. Especially on the first slide, you could see the severe hyperkeratosis, thickening of the stratum corneum, which has spread to the hair follicle. There is marked parakeratosis, preservation of the nucleus in the stratum corneum, hypergranulosis, and irregular acanthosis, thickening of the epidermis. Normal adnexal structures were present. The underlying dermis had no obvious abnormalities. On the second slide, you could see the hyperkeratosis of the epidermis with uneven acanthosis and normal condition of the granular layer, concentric accumulation of keratotic material around the hair shaft in the hair follicle. In the stratum corneum, there are spaces with dilated orifices of the eccrine sweat glands. Lamellar ichthyosis. This form of ichthyosis is inherited by autosomal recessive type. The disease manifests itself immediately after birth as a colloidal fetus. The hyperemic skin is covered by a thin yellowish film resembling collodion. Later, the colloidal film turns into large scales, lamellar exfoliation of the newborn. In most cases, the scales formed from the film remain for life, which aids the skin hyperemia subsides and the hyperkeratotic phenomenon increase. The process spread to the fold. The skin of the face is hyperemic, taut, and covered with scales. The scalp is also covered with multiple scales. Hair and nails grow back quickly. There is increased sweating on the palm and soles. Hyperkeratosis of the palms and soles is lifelong. Characteristic features of this dermatosis are lack of thalamus, keratitis, photophobia, ectropion. On this slide, you could see the typical clinical feature of lamellar ichthyosis. On the left slide, you could see the skin of the patient that covered with multiple scales. In the center slide and right slide, you could see the typical clinical feature of lamellar ichthyosis of the adults and babies. The skin of the patient is hyperemic and covered with yellowish film resembling collodion. On the slide, you could see the histopathology of lamellar ichthyosis. Especially, you could see the proliferative hyperkeratosis, moderate acanthosis, hypertrophy of dermal papillae, perivascular infiltrates surrounding the blood vessels. Epidermolytic ichthyosis, a rare form of congenital ichthyosis inherited autosomally and dominantly. It appears immediately after birth as scalded skin. The skin of the newborn is bright red. There are extensive areas of skin detachment with the formation of erosion and blisters. Anechoic symptoms are positive. The skin of the palms and soles has thickened. With age, the number of blisters decreases and the keratinization of the skin increases. The prevalence of epidermolytic ichthyosis is estimated at 1 to 200,000 to 1 to 300,000. The disease is caused by a mutation in the gene encoding epidermal suprabasal keratin 1, which damage intermediate keratin filament, as suprabasal keratinocytes, hyperkeratosis, and in most cases generalized, but some patients have limited skin lesion, particularly at the joint, on the anterior surface of the neck, on the abdominal wall, and in the pudendal fold. Some patients have symptoms on the palms of the hand and soles. The skin is often itchy and has an unpleasant odor, and skin infection may occur. Other features of the disease may include hyperhidrosis, scaly scalp, and nail dystrophy. On the slide, you could see the clinical feature of epidermolytic ichthyosis. You could see the babies that suffered from epidermolytic ichthyosis. You could see the multiple erosion on the skin surface. On the slide, you could see histopathology of epidermolytic ichthyosis. You could see the acanthokeratotic hyperkeratosis, horny layer thickened, parakeratosis in place, intracellular edema on the thorny layer, inflammatory infiltrate in the dermis. On the right slide, you could see the massive orthohyperkeratosis, acanthosis, vacuolization of the suprabasal keratinocytes with hypereosinophilic granules, irregular distribution of keratodyalin, staining with hematoxylin. Ichthyosis hystrix. Cass-Macklin syndrome, a rare form of ichthyosis, is inherited in autosomal dominant way. At the birth of child, the clinical picture only by eczema without peeling and blisters was manifested. Within a few weeks, the eczema subsides and scaling and hyperkeratosis such as yellow, brown, or gray, spiny, cobblestone, hystrix, or verrucous develops. Hyperkeratosis is often diffuse and more on the external surface of the extremities, limbs, and trunk where pronounced. Lesion may also be nevoid, phelone, blascoline. Patients also suffer from striated or diffuse palmoplantar keratoderma. As the disease progresses, palmoplantar keratoderma intensify and lead to deep bleeding. Painful cracks in severe case palmoplantar keratoderma can also lead to contracture, gangrene, and loss of fingers. Skin infection is often observed by an unpleasant odor as accompanied. Nail dystrophy, phenomena of onychogryphosis as observed. The form of ichthyosis in men with mental retardation, imbecility, and epilepsy were combined. The syndrome results from a heterozygous frameshift mutation in the region of the KRT1 gene encoding keratin 1. This mutation results in abnormal supramolecular organization of keratin intermediate filament and may be associated with defect in cytoplasmic traffic and the integrity of cellular structure, such as organelles and nucleus. On the slide, you could see the clinical feature of ichthyosis hystrix, Cass-Macklin syndrome. On the left slide, you could see the multiple verrucous lesion on the lower extremities of the patient. On the central slide, you could see the appearance multiple scaly and verrucous rashes on the chest and abdominal areas of the patient. On the right slide, you could see multiple rashes on the face area and on neck of the patient. On the slide, you could see the histopathology of the Cath-Macklin syndrome. On the top slide, you could see the typical hyperkeratosis, acanthosis, and papillomatosis with the thick granular layer. In the bottom slide, you could see the hyperkeratosis with perinuclear vacuolization of epidermis and large keratohyalin granule in the upper part of the spiny layer of the epidermis. Diagnosis of ichthyosis. The following measures will be conducted. First, clinical picture, medical history, if necessary, pathological examination of skin, biopsy specimen, electron microscopy of skin, biopsy specimen, detection of small, immature keratohyalin granule as an additional diagnostic tool. Second, in X-linked ichthyosis prenatal diagnosis based on steroid sulfatase activity in amniote, cell, culture, or chorionic tissue. Southern DNA blood hybridization of peripheral lymphocytes, detection of cholesterol sulfate by quantitative plasma spectrometry. Differential diagnosis of ichthyosis. The fellow dermatoses must be differentiated from the following disease: Leiner-Musso desquamative erythroderma, Wilson-Brock type exfoliative erythroderma, Netherton syndrome, psoriatic erythroderma, erythrodermic form of lichen pilaris, erythrokeratoderma. Treatment of ichthyosis. In various forms of ichthyosis, preparation containing vitamin A are used. They are prescribed in the form of drops, capsule, intramuscular injection up to 400,000 international units per day for 2-3 months. Retinoid acid derivative in clinical practice, tigazone, neotigazone, at the rate of 1 mg per kilogram are used. The duration of the course of treatment is from 2-3 months to 1 year. Assigned B vitamin, nicotinic acid, hypertrophic drug, in severe cases, corticosteroid preparation. Physiotherapeutic procedures are widely used: dry air or water bath, salt bath, ultraviolet irradiation in suberythemal doses in combination with oxygen bath will be applied. The therapeutic effect gives photochemotherapy. Externally, keratolytic ointment with vitamin A are used. Ointment with retinoid are also recommended. To eliminate honey layer in ichthyosis, a 10% ointment with urea, 1 to 20% malic, citric, glucuronic or pyruvic acid as used. Moisturizing cream with good effect are used. Newborn children with ichthyosis and intensive care in incubator will be needed. Systemic corticosteroid, antibiotics are prescribed. The use of keratolytic agent is not advisable. Netherton syndrome. The syndrome includes lamellar ichthyosis, manifestation of atopy, bronchial asthma, allergic rhinitis, neurodermatitis, atopic dermatitis, anomalies of the hair shaft like trichorexis invaginata, bamboo hair, aminosudorrhea. Sometimes, instead of lamellar ichthyosis, manifestation of common envelope of linear ichthyosis are observed. In children, there are phenomena of enteropathy sepsis were revealed. The frequency of the syndrome as 1 to 200,000 of the population was found. Children suffering from this syndrome, a high blood level of aldosterone, sodium, renin, growth hormone deficiency as observed, molecular analysis of DNA in a child in the SPINK5 gene revealed, heterozygoty, frameshift mutation, 238 in J and 246ADI1A in exon 4 and 26 respectively in the maternal allele and 1431 12G more A splice site mutation in intron 15 in the paternal allele, as well as missense variant I 420K in the homozygous state was indexed. On this slide, you could see the baby that suffering from Netterton syndrome. You could see the diffuse hyperemia of the skin and desquamation. On the right slide, you could see the typical clinical sign of the Netterton syndrome, the bamboo hair sign. On this slide, you could see the histopathology of the Netterton syndrome. You could see the moderate acanthosis and hyperkeratosis with loss of the granular layer of epidermis. Diagnosis of Netterton syndrome. Netterton syndrome is diagnosed on the basis of symptoms and confirmed by genetic testing for change in the SPINK5 gene. Other types of testing, such as careful examination of the hair and skin biopsy to obtain a small skin sample for examination under a microscope, may also be useful for diagnosis. Treatment of Netterton syndrome. Treatment is symptomatic and requires rapid management of neonatal complications and long-term use of mitigating agent to treat the skin disease. The use of topical steroids and topical immunomodulators, tacrolimus and pimecrolimus, has been described as useful in some cases, but these agents are not indicated for long-term use or treatment of large areas, as the skin barrier defect allows increased systemic drug absorption. Refsum syndrome. The disease is characterized by vulgar ichthyosis in combination with cerebellar ataxia, peripheral neuropathy, retinitis pigmentosa, and deafness. The syndrome by autosomal recessively pathway was inherited. More than 90% of all cases of Refsum disease by mutation in the PHY8 gene occurs. The remaining cases by mutation in a gene called PIX7 occurs. The symptoms of the Refsum disease occur as a result of anomalous accumulation of fatty acid called phytanic acid. Mutation in the PHY8 or PIX7 gene disrupt the normal function of peroxisome, including the breakdown of phytanic acid. As a result, these substances accumulate in the body tissues. The accumulation of phytanic acid is toxic to cells. These substances come from food, especially beef and dairy products. It is usually split in the process called alpha oxidation, which occurs in cellular structure called peroxisome. This structure contains enzymes that split many different substances, such as fatty acids and some toxic compounds. On this slide, you could see the typical clinical feature of Refsum syndrome. On the top slide, you could see the limb disfigurement as a result of peripheral neuropathy and appearance of vulgar ichthyosis on the skin surface. On the bottom slide, you could see the clinical feature of retinitis pigmentosa. Treatment of Refsum syndrome. The main method of treating Refsum syndrome is to limit or eliminate products containing the phytanic acid, including dairy products, beef and lamb, as well as fatty fish such as tuna, cod, and pike. In some cases, patients need plasma transfusion, plasmapheresis, in which blood is closed, filtered, and transferred back to the body in order to reduce the content of phytanic acid in peripheral blood. Root syndrome, hereditary, autosomal, recessive symptom complex characterized by neuroendocrine dysplasia, including congenital ichthyosis, epilepsy, mental backwardness, polyneuritis, pigment retinitis, as well as, in some cases, combination with macrocytic anemia and infantilism were manifested, described in 19 and 27 by Root. In the affordable world literature, about 55 cases of Root syndrome were described. In a patient suffering from Root syndrome, an increased level in the peripheral blood of alkaline phosphatase, folliculin stimulating and luteinizing hormone, low content of calcium blood serum was revealed. The nature of the inheritance and the nature of the primary genetic defect of Root syndrome is not known. Although an autosomal recessive and X-clustered model of inheritance were proposed, the main anomaly of deleting the thyroid sulfatase gene leading to the deficit of above-mentioned enzyme was considered. On the slide, you could see the typical clinical feature of Root syndrome. Especially, you could see the congenital ichthyosis and polyneuritis. On the slide, you could see the histopathology of Root syndrome. Especially, you could see the hyperkeratosis, club-shaped reticular ridge, thinning of the suprapapillary epidermal lamellae, with mild mononuclear inflammatory cell infiltrate in the dermis. Treatment of Root syndrome. The treatment of the syndrome as symptomatic. Involvement of related specialists in the treatment. Neuropathologists, therapeutics, ophthalmologists, endocrinologists, and in some cases, psychiatrists. Dermatologist treatment include topical ichthyosis emollient such as soap, paraffin, keratolytic, topical retinoids, and vitamin D3 analogs. Sjögren-Larsen syndrome. This form of the disease was described by Swedish neurologist Sjögren and Larsen. Syndrome is characterized by a manifestation of congenital ichthyosis, the skin of the face, the scalp, the crowd, the axillary armpits is not involved in the skin. Patients suffer from oligophrenia, spastic little type diplegia. Degenerative change of the retina, teeth defect, and bone anomalies are observed. The type of inheritance is autosomal recessive. Sjögren-Larsen syndrome. FADH fatty aldehyde dehydrogenase localized on chromosome 17p11.2. Frequency of syndrome 1 to 215,000 population. The FADH gene controlled enzyme is responsible for splitting certain molecules of medium and long-chain fatty aldehydes. In case of violation of FADH function, the metabolites are accumulated in the body, especially in the skin membrane and the brain, which lead to the symptom associated with the above syndrome. On this slide, you could see the clinical feature of Sjögren-Larsen syndrome and histological examination of above-mentioned syndrome that characterized by orthohyperkeratosis, acanthosis, papillomatosis, and normal layer of granular cells, and weak inflammatory infiltrate in the upper part of the dermis was revealed. Diagnosis of Sjögren-Larsen syndrome. Molecular genetic study may be performed to look for mutation in the ALG83A2 gene. 95% of patients have two mutations in this gene, resulting in the symptom seen in Sjögren-Larsen syndrome. Treatment of Sjögren-Larsen syndrome. Treatment of syndrome symptomatic and as aimed at eliminating symptoms as they appear. Therefore, they may need to help several different specialists. The child care team with Sjögren-Larsen syndrome may include specialists on the problem of the nervous system, neurologists, specialists to evaluate and treat skin problems, dermatologists, ophthalmologists, experts to assess and treat problems of the skeleton and related muscle and joint, orthopeds, as well as physiotherapeutics. A dietary power is recommended with a low content of long-chain fats, such as oil, fish, nuts, avocado, and meat, and supplemented with triglycerides, such as dairy products and coconut oil, contribute to improving the condition of the skin in some patients. Tools are used to reduce skin peeling, including keratolytic ointment and urea-containing lotion or creams. Conradi-Hunnermann congenital calcific chondrodysplasia. This nosology was described by the German pediatrician Konrad Erich in 1914 and Hunnermann in 1931. Conradi-Hunnermann syndrome is caused by a specific change that disrupts the function of the emopamil binding protein gene XP11.22 P11.23. This gene encodes a substance called 3-beta hydroxysteroid delta 8 delta 7 isomerase or sterol delta 8 is isomerase. This enzyme plays an important role in the last stages of cholesterol synthesis. Violation of the synthesis of sterol delta 8 isomerase leads to the accumulation of cholesterol precursor sterol with a toxic substances. Clinically, the syndrome is manifested by the following picture. First, growth disorder of the long tubular bone, shortening of one or more, less often all four limbs, especially the thigh and shoulder. Development, often only partial, of a chondrodystrophic trunk. 2. Restriction of movement in large joint, knee, hip, elbow. 3. Dystrophic change in the foot, per varus, per calcaneus, less often the hand, shortening, syndactyly, campodactyly, or vertebrae, wedge-shaped vertebrae, kyphosis. 4th, relatively large skull with retracted angle of the nose. 5th, other malformations are also often observed: congenital cataract, congenital ichthyosis, congenital heart defect, kidney malformation, cleft lip, vascular nevi. The skin of the trunk is dry, with foci of erythema, hyperkeratosis, patchy hyperpigmentation, diffuse keratoderma of the palm, hyperkeratosis, trichosis, and alopecia are observed. 6. Radiological data, small, usually correctly grouped calcium deposits in all preformed cartilaginous part of the skeleton, especially pronounced in the epiphyses of the extremities, dotty epiphyses. The gradual development of change is very variable. There are also abortiform. Over the course of a number of years, the change undergo involution. In the addition to the main lesion, there are shortening of all or individual tubular bones and sometimes mushroom-shaped expansion of the metaphyses, similar to classical fetal chondrodysplasia. X-linked dominant hypoichthyosis is manifested by punctate atrophoderma, pigmentation, and skin flaking with a linear arrangement of chains. On the slide, you could see the clinical feature of Conrad-Hünermann syndrome. Especially, you could see the skin manifestation with orthopedic anomalies, yellow-white hyperkeratotic scales on the back, distributed along Blaschko line. On the right slide, you could see the feather-like yellow scales have been found along Blaschko line. On the slide, you could see babies that suffered from Conrad-Hünermann syndrome. Especially, you could see the asymmetric rhizomelic shortening of the upper limbs, right only. And on the right slide, you could see the polydactyly of left wrist. On this slide, you could see the X-ray investigation of the tubular bone of a child with Conrad-Hünermann syndrome. Especially, you could see the pinpoint tap calcification in both epiphyses of the femur that shows with red arrows. Diagnosis of Conrad-Hünermann syndrome. The diagnosis of Conrad-Hünermann syndrome is based on the identification of characteristic symptoms, a study of the medical history, a thorough clinical examination, and various specialized research methods. To establish the diagnosis of Conrad-Hünermann syndrome, radiographic, ophthalmological, dermatological, histological, and biochemical studies are necessary. An X-ray examination can detect characteristic spotting of the epiphyses, speckled calcium deposits in the bones and other areas of the cartilaginous skeleton. However, over time the characteristic epiphyseal deposits are lost, which can make diagnosis difficult. An important point for confirming the diagnosis of Conrad-Hünermann syndrome is a blood test to detect elevated levels of sterol. Genetic change in the IBR gene contribute to an increase in the level of sterol, especially 8,9 cholesterol and 8 dehydrocholesterol, both in the blood and in some tissue of the body. Histological allows to review the phenomena of hyperkeratosis in the mouth of the hair follicle with calcium deposition. This finding is characteristic of Conrad-Hünermann syndrome, but may also occur in some other disease. Treatment of Conrad-Hünermann syndrome is aimed at eliminating specific symptoms in patients, requires the effort of many medical professionals such as pediatricians, orthopedists, dermatologists, ophthalmologists, and other specialists. To prevent, treat, or correct certain skeletal abnormalities, various orthopedic measures, including surgery, may be recommended. Surgery may also be recommended for certain craniofacial deformities, scoliosis, or other physical abnormalities. The surgical procedure performed will depend on the nature, severity, and combination of anatomical abnormalities, associated symptoms, and other factors. Recommended treatment for congenital cataract may include early surgical removal of the cataract, implantation of artificial lenses in some patients, or certain activities after surgery, the use of corrective lenses to achieve good vision. For people with ichthyosis and skin abnormalities, bath with the addition of fresh oils, the use of moisturizing and softening ointment and emollients may be recommended. Sunscreens are recommended. People with hearing loss need to be treated by an otolaryngologist. Genetic counseling is indicated for patients and their families. Erythrokeratodermia. The group of erythrokeratodermias includes dermatoses with keratinization disorders of the type of hyperkeratosis occurring against the background of an inflammatory reaction. There are several varieties of erythrokeratodermia, especially erythrokeratoderma variabilis Mendes da Costa, erythrokeratodermia progressiva symmetrica Darrieux-Gautron, Digos, erythrokeratodermia encocardas, erythrokeratodermia confluens reticularis Gougerot-Cartot, erythrokeratodermia variabilis Mendes da Costa syndrome. The disease manifests itself in the first month of life. It is characterized by the appearance mainly on the extremities of symmetrical areas of erythema with raised edges, the size and shape of which change within a few hours. In the erythema zone, foci of hyperkeratosis form. Unlike erythema, they retain their shape for a long time. The palms and soles are not affected. Sweating is normal. Patients are concerned about itching, a feeling of tightening of the skin. Erythrokeratodermia variabilis, characterized by heterozygous dominant inheritance, mutation associated with erythrokeratodermia variabilis in gene encoding CX31 or CX30.3 and sometimes CX43 are located. This protein connectin 31, connectin 30.3 and connectin 43 are gap protein transition which belong to a large family of transmembrane proteins that form intercellular channels. Intermediates are responsible for the exchange of metabolites, ions, and second messenger between cells. The human connectin family consists of at least 20 different proteins, and most cells and tissue types express more than one connectin gene. Connectin 31 in the skin, peripheral nerves, and the cochlea was expressed. CX30.3 in the skin, kidney, and pre-implantation blastocysts as expressed. CX43 as expressed ubiquitously. All reported mutations in erythrokeratoderma variabilis are non-conservative amino acid substitution mutation resulting in impaired epidermal differentiation. On this slide, you could see the clinical feature of erythrokeratodermia progressiva variabilis, Mendes da Costa syndrome. On the left slide, you could see the typical clinical feature of disease that characterized by appearance of hyperkeratotic spots and plaques with raised edge. On the central slide, you could see the localization of hyperkeratotic spots and plaques that localize on the thigh areas. On the right slide, you could see the localization of hyperkeratotic plaques that localize on the buttock areas. On the slide, you could see the specific histopathology of Mendes-da Costa syndrome. You could see the following histological features, especially the phenomena of acanthosis with overlying hyperkeratosis in epidermis was revealed. There are focal areas with a pronounced granular layer interspersed with areas of loss of the granular layer, over which there are 2-3 layers of parakeratosis, turning into compact orthohyperkeratosis. The dermis has a sparse, superficial, perivascular lymphocytic infiltrate associated with dilated blood vessels. Erythrokeratoderma progressiva symmetrica Dariegatron. Dermatosis inherited by autosomal dominant pathway. The disease is manifested in the first year of life. It was reported that a mutation is associated with this disease in the KDSR gene. This gene encodes 3-beta-dehydroxyphingosine reductase, the enzyme involved in the synthesis of ceramides. According to other data, a mutation with a change in the loricrin gene on chromosome IQ21 was revealed in Japanese family with Erythrokeratoderma progressiva symmetrica Dariegatron and mutilating palmoplantaris keratoderma. The RNS mutation in the GJB4 gene was detected in 2 independent patients with Erythrokeratoderma progressiva symmetrica Dariegatron, fixed symmetrically arranged and centrifugal growing flexes with a clearly defined hyperpigmented edge appear on the skin of the limbs. In the foci of lesion, epithelioma spinocellulare is often developing. Localization of the foci on the front surface of the leg, the rear surface of the hands, the area of the nipple, of the mammary gland, palms and soles are usually not involved. Dystrophy nail was observed. On the slide, you could see the clinical feature of erythrokeratoderma progressiva symmetrica Dariegatron. Especially, you could see the erythematous hyperkeratotic scale plaques over knees on rear of hands. On the left slide. On the right slide, you could see the rear of side of feet with erythematous and hyperkeratotic plaques and dystrophic nails of toes. On the slide, you could see the typical histopathology of the Dariegatron syndrome. Especially, you could see the phenomena of hyperkeratosis, parakeratosis, and acanthosis with slight spongiosis of the epidermis, as well as spotted lymphohistiocytic infiltrate in the upper part of the dermis. Erythrokeratoderma confluent reticularis Gougerot-Carto. Erythrokeratodermia confluent reticularis Gougerot-Carto was described in 1928 by French dermatologists Gougerot and Carto under the name Papillomatose pigmenti in nomine, and then in Carto dissertation under the name Papillomatose confluent et reticuli, and further became a common term. The etiology and pathogenesis of erythrokeratodermia confluens reticularia Gougerot-Carto are not fully understood. There are different points of view regarding the possible mechanism of the development of the disease, including vitamin A deficiency, pityrisporum skin colonization, reaction to ultraviolet radiation, a type of black acanthosis, menstrual, irregularities, a clinical variant of skin amyloidosis, endocrine pathological processes such as diabetes mellitus, obesity, thyroid disease. That dermatoses has been described in at least one patient with hyperthyroidism. In Japan, 76.5% of cases are associated with obesity or rapid weight gain. A similar clinical and histological picture of Gujarat-Carto papillomatosis reticularis and black acanthosis as reported. However, the latter occur in older people and associated with endocrine pathways and oncological disease. The clinical feature of dermatoses is characterized by appearance of rashes first on the skin of the chest and along the midline of the back, gradually spreading to the skin of the entire surface of the chest, neck, armpits, and abdomen. Occasionally, rashes may occur diffusely on the skin of the shoulders, pubic region, and face, clinically manifest by appearance of hyperkeratotic or verrucous papules, the color of which varies from brown to pink and the size reach up to 5 mm. Papules meet in the center, forming plaques with indistinct boundaries resembling a mesh pattern along the periphery. The peak of incidence occurs between from 10 and 35 years of age. Women get sick more often than men, with the exception of Japan, where the disease occurs predominantly in men. As a rule, the disease begins immediately after puberty. On the slide, you could see the typical clinical feature of Gujarat-Carto syndrome. On the slide, you could see the histopathology of Gujarat-Carto syndrome on the skin. On the left slide, you could see the phenomena of hyperkeratosis. Papillomatosis in epidermis was revealed, moderate perivascular infiltration of the dermis. On the right slide, you could see the moderate acanthosis and unexpressed papillomatosis of epidermis, slight perivascular lymphocytic infiltration of the dermis. Gigos erythrokeratoderma encocardes. Erythrokeratoderma encocardes, a rare variant characterized by polycyclic, concentric, and target light lesion along with erythematous plaque. Because erythrokeratoderma encocardes is considered to be a type of Mendes da Costa variable erythrokeratoderma with undetermined mode of inheritance. One patient without a family history of the disease was found to have a mutation in the GJB3 gene. The disease manifests itself from early childhood. Clinically, disease is characterized by the appearance of cercenary erythematous squamous foci with horny layers in their central part, resembling a cockade and a slightly elevated edge. The foci are located on the buttock, shins, less often on the chest, abdomen, upper limbs. There are fixed hyperkeratotic area on the knee, slight peeling on the face. There is slight hyperkeratosis on the palm and sole. There is an undulating course of remission of disease followed by relapses. On this slide, you could see the Gigos erythrokeratoderma encocardes. You could see the localization of pathologic process on the upper and lower extremities. The localization of hyperkeratotic plaques on axillary areas surrounded by erythematous rims. On the slide, you could see the histopathology of Gigos erythrokeratoderma encocardes. you could see that acanthosis with mild papillomatosis and orthokeratotic hyperkeratosis of epidermis, mild perivascular lymphocytic infiltration of the dermis. Diagnosis of erythrokeratoderma. The diagnosis of erythrokeratoderma is based on the identification of characteristic symptoms, study of the anamnesis, clinic and cause of the disease, and thoroughly paraclinical examination using spatial tests, including genetic testing and histological examination of skin biopsies. Treatment of erythrokeratoderma. Treatment of erythrokeratoderma is aimed at addressing the specific symptoms present in patients, such as keratolytic therapy with skin softening ointment, emollients. Some but not all people with erythrokeratoderma may also benefit from treatment with keratolytic. Other keratolytics include the use of lotion containing alpha-hydroxy acid, propylene glycol, lactic acid, vitamin D analogs, calcipotriol, or urea, narrow-band ultraviolet B light with systemic retinoid can be used with some success in some patients with severe erythrokeratoderma, but these have serious side effects or adverse reactions that require careful monitoring of patients during treatment. Other treatments are symptomatic. To prevent the risk of having children with this disease, genetic counseling as recommended. New therapeutic option aimed at specifically inhibiting the function of overactive connexin hemichannel anti-malarial drug gentamicin are currently being explored, which may be promising therapeutic agent. References. Thank you for attention.